I think we've heard a lot about CML over the last 2 days, and I think what is clear is that CML is a stem cell disease. And as you know, the CML stem cell is independent of the BCR-ABL kinase activity. So I think if the way that we are treating CML today, it's unlikely that we are able to eradicate the CML stem cell per se, which exists in small quantities. And I know researchers are actively looking at various genetic mechanisms that this CML stem cell is dependent upon. And depending on whether it has any special characteristics or the bone marrow has any particular niche or any characteristics that supports these CML stem cells, and if we are able to identify that, then perhaps one of these days we may be able to eradicate the CML per se within our body. So I think it is still reasonable to say that replacement of the stem cells or a stem cell transplantation is the only curative therapy as far as we know. While TKIs do not eradicate the stem cells, it is able to get these cells, the proliferative cells, to very, very low levels. And the PCR testing that we do today really tests the messenger RNA transcripts, which is the activity of the CML. So even if you get into a negative PCR, if you were to do very sensitive DNA testing on the patient sample, you are able to still detect the CML DNA within these patients. But what is exactly happening, we are still unclear, because obviously there are patients who live with their CML without evidence of the disease, without needing TKI for at least 8-10 years, and whether eventually they will relapse or whether there's some other mechanism that is able to control these stem cells, I think remains to be elucidated. I'll just show you a slide on the outcome of stem cell transplantations, and this came from the International Bone Marrow Transplant Registry, looking at 5,000 over patients that were performed within 1998. First of all, I apologize that the follow-up is really very slow, still very short, but actually there are longer studies that goes up to 15 to 20 years. And if you look at the chronic phase CML, and they were comparing those within the first half of the decade and the second half of the decade, roughly about 65% of the patients' chronic phase are still alive. And if you were to follow them up, they still drop about 5 to 10% percentage points after. That means even up to 10 to 15 years, there will still be 1 or 2 patients who continue to relapse from that CML. But I would say that overall, on the long term, I would say 60% of patients with chronic phase CML who were transplanted are actually cured of their disease, if that is the correct term to use. You know that CML, you've heard a lot about stem cells yesterday and today, and you know that stem cells have 2 capacity or 2 capability. One is the ability to differentiate into mature cells, and CML stem cells are able to proliferate and differentiate into the myeloid lineage as well as the B lymphocytes. But one of the other characteristics of the stem cell is its ability to self-renew and keep itself alive for many, many years to come. So it persists on in the system. And where do we get these stem cells? And here I actually refer to hemopoietic stem cells, because obviously you also have cardiac stem cells, you've got neural stem cells, you've got liver stem cells. But as far as the hemopoietic stem cells is concerned, it actually rests largely inside the bone marrow. Within our bloodstream, there is a very, very small quantities of stem cells which are circulating, but if we were to give you a certain growth factor like GCSF to stimulate these stem cells, you are able to get them in very high quantities, and in which case then you are able to isolate those stem cells using what we call an apheresis technique. So you can largely get stem cells from bone marrow as well as a GCSF stimulated blood. And the other source is really inside the cord blood. So this was me when I was a young, enthusiastic hematologist, going into the operation theater, sucking out the bone marrow stem cells from our patient who is under general anesthesia, lying prone here. We usually aim for a certain cell dose, and ultimately what we get is about 1 to 1.5 liters of bone marrow. And these are very rich in stem cells, all right? So generally the procedure lasts about 45 minutes to 1 hour. But nowadays, we do what we call peripheral blood stem cell harvesting. That means after 4 to 5 days of growth factor using GCSF, we put the patient on a machine, which is known as the apheresis machine, and we process the blood. And usually after processing the blood, we will get 100 to 150 mils of blood, which is very rich in stem cells. And this is what we mean when we say peripheral blood stem cells. And because we take so little in volume, if we fail to get a certain number of stem cells, the next day we can still collect, and we can still collect on the 3rd day. Whereas if you were to do a bone marrow, you've already taken one huge chunk, which is 1 liter, and there's no way that you can go on and get another sample the next day. So there are advantages and disadvantages of bone marrow and peripheral blood stem cells, right? Bone marrow is the traditional source, but unfortunately, you need to go for general anesthesia. It causes low back pain. And then there is this peripheral blood stem cells whereby the donor doesn't have to go for general anesthesia, but can donate, and you can collect 10 times or more stem cells. And there are a lot of transplanters who like to argue amongst themselves, which is a better source of stem cells? Is it bone marrow? Is it peripheral blood stem cells? Which is safer? Which is more effective? And I think the argument is largely rhetorical and redundant, because I don't think many of us want to go back to the operation theater and suck out bone marrow from our patients. You have to fight with the surgeons for OT time. The general anesthetic people hate you, And if you run a very busy transplant unit, you don't want to every week, have to go in 2 or 3 times, fighting with your surgeons. So I think the real question is that, is there any indication whereby we really need bone marrow stem cells? The other thing is that, how to make peripheral blood stem cells as safe as possible, because that will be the easiest to do, all right? And thirdly, of course, of the cord blood transplants, whenever a woman gives birth, you have the placenta, and this is the umbilical cord. And inside this blood here is very rich in stem cells. And you can actually collect, because this is largely discarded, all right? And these cells are actually stored in small bags, what we call cryocyte bags, or in little vials, and they are already stored in tanks and ready for use. So there are advantages to using cord blood transplants, because it is rapidly available, it's already there. The blood testing has already been done, the matching has already been done. You don't have to go around looking for a donor. The donor may be a volunteer at the registry, but when you need him, he may not be available, or he has already changed his mind. So there is actually a no donor attrition and so forth. The only problem for us, for adults, is that usually the cord blood cells are small in quantity, and it's not enough to do for an adult to undergo a stem cell transplantation, and sometimes you need 2 or 3 bags of cord blood. So how do we exactly do a bone marrow transplant? First of all, of course, you need to eradicate those stem cells, all right? That includes the CML leukemic stem cells. So the subject has to undergo very intensive conditioning. This conditioning will kill off every single stem cell that is inside the body, all right? And then after that, we infuse those stem cells, all right? And inside the stem cells are the stem cells itself, as well as immunoeffector cells, which are the lymphocytes. Because it is really these immunoeffector cells which are able to recognize the leukemia cells and try to eradicate whatever residual leukemic cells that are still persistent, all right? So this is what we call graft versus leukemia effect. So the traditional way of doing a transplant is really very toxic, because you need very high-dose chemotherapy to really kill off every single stem cell. And therein lies the problem, because you require the patient to be in very good performance status. They have to be very good cardiac function. They have to be young. They have to be fit, all right? But over the years, we realized that you actually don't need to eradicate every single stem cell inside the body, all right? You only need to partially eradicate the stem cells, and leave the immunoeffector cells or the lymphocytes to do the rest of the work. Why do we need to do that? It's because majority of our patients are not fit. When they have leukemia, they are not really in the best condition. All right, many of our patients are elderly, some have medical comorbidity, some are diabetic, hypertensive, some have hepatitis B, some have infections, right? And you really want the stem cells to be available to as many patients as possible. So this is what we call, in the past, a mini transplant or a non-myeloablative transplant. The other advantage is that it has lower transplant-related deaths, and it also preserves fertility, because the high-dose conditioning takes away the fertility of most of our patients, or almost all our patients. So if you have a young patient who wishes to preserve the fertility, perhaps a reduced intensity or non-myeloablative transplant is a better option. Now, this has been also studied in the European Bone Marrow Transplant Registry, and it's shown that, reduced intensity conditioning or non-myeloablative conditioning does work in CML. All right, the transplant-related mortality is much lower, about 6 to 10%, and its efficacy is just as good. But perhaps it is not as effective in the advanced phases. So if you are in a chronic phase, you may want to opt for a reduced intensity, but if you're at advanced phase, you probably want a little bit more intensity than the usual non-myeloablative, all right? So why don't we just transplant everybody? All right, because, obviously it cures, it is accessible to many of us, all right? Unfortunately, it's toxic. It is this conditioning that you need to undergo, and there is this risk that you need to undergo every time. At least within the first 3 months, but up to 2 years, you have a risk of dying from a stem cell transplantation. All right, whereas when you're using a TKI, obviously you don't have that risk, right? So there is this problem of graft versus host disease. Whereas I told you about these immunoeffector cells or these lymphocytes that goes in with your stem cells. They are able to recognize the leukemia cells as foreign and eradicate it. Unfortunately, they are still also able to recognize the patient as being foreign. And it also mounts an attack on the remaining organs of the patient. And this is what we call graft versus host disease. And although transplants today are much safer, we are still not able to prevent graft versus host disease totally, all right? Unfortunately, also, not everyone has a matched donor, and you've heard over the last 2 days, today we have a much safer first-line and second-line option, so transplants go down the list. So this is graft versus host disease, and much like a Sokal score, although you have a high Sokal score and we say 80% will do well with nilotinib, there's 20% who won't do well with nilotinib. Unfortunately for you as an individual, we are not able to say, are you in the 80% or are you in the 20%? The only way that we can know is, if we give you a course of treatment and then see whether you are the 80% or 20%. Similarly, for graft versus host disease, although we have various risk factors that tell us who is at the higher risk of graft versus host disease, we are not able to identify every individual patient, what is your risk of graft versus host. If we did that, if we knew that, then the options of weighing which one is better is easier. We can only tell you what is your percentage chance, but we cannot tell you your individual risk. I think therein lies the problem with a stem cell transplantation. You can have a young patient who gets very bad graft versus host disease. You can have an elderly patient who sails through the transplant, without any problems, and there's no way of telling who will get what. So if you look at the incidence of graft versus host disease in Malaysia, it is just as high as that in the other countries, all right? And this is from our abstract. And finally, Malaysia is made up of a few major ethnic groups. We have the Malays, the Chinese, the Indians, and as well as the others. All right, so Malays tend to get more graft versus host disease. So when we look at all the causes of death within our transplant cohort, Malays tend to die more of graft versus host disease, whereas Chinese tend to get less graft versus host disease, and because of that, they die less of graft versus host disease. But unfortunately, because they have less graft versus host disease, they have a higher incidence of relapse. So many of them, die of a relapse instead. So really, it is a balance of one from the other. But 10 to 20% of patients still die of infection after a stem cell transplantation. So there is always that risk of doing a transplant, all right? 30% of patients, of course, cannot find a donor match. Even within our ethnic groups, whereby there are certain ethnic groups with very large families, 5 siblings, 7 siblings, our chance of getting a HLA match is still only about 23%. Or that means 70% of our donors will not be able to get a match. And if you go into an international registry whereby you are underrepresented, if you are Caucasian today, your chance of getting a match is high. But if you are, say, a Malay ethnic group, your chance of getting a match is low because it's really underrepresentation of your particular ethnic group in that registry, all right? So there will still be a certain percentage of people with no donors. So it is obvious then, if you look at the registry data, again, in the International Bone Marrow Transplant Registry, on the activity of transplants over the years, you can see CML since the year 2000 onwards, started with about 2,000 per year, now has come down to about less than 500 per year. Whereas the other, like acute myeloid leukemia, the incidence really has increased slightly somewhat. So CML, the activity for transplants really have come down over the years. This is just a graph to show you the difference between peripheral blood stem cells and bone marrow. This is again in the International and the European Bone Marrow Transplant Registry that looked at about 800 patients. So if you're in chronic phase, using a bone marrow has a peripheral blood, has a stem cell source, is almost equal. Perhaps bone marrow is just slightly better, all right, you get on this curve. But if you're advanced phase, then a peripheral blood stem cell is much better than if you were to do a bone marrow. So you obviously can see there is a difference in outcome using different marrow sources. This is looking at about 3,000 patients in the US National Marrow Donor Registry, comparing different donor sources. If you have a brother-sister match, then your outcome is better. If you didn't have a brother-sister match, you have to resort to an unrelated match. The outcome is about 10% lower. Then, but still, that, although there are very good centers in the world that says, they are roughly equal, but majority will say that, your difference is still about 10% difference in the outcome. And this is from the Japanese registry that look at cord blood transplants, and, they looked at 86 patients, and if you are chronic phase, it is really quite decent in the overall survival. So there are actually many sources of stem cells, and if you were to do a transplant, your outcome can still be just as good. Over the last few years, we realized that, there are still a significant proportion of our patients who still cannot get a match, all right? You don't have a brother-sister match, you don't have an unrelated donor match. And we, like many others, have also been looking at and performing what we call haploidentical transplants. Haploidentical transplants really means just taking a match from your mother or father who is same on one chromosome, but the other chromosome is totally unmatched. Obviously, the child here gets one chromosome from the mother and one chromosome from the father. So this child will be a haplomatch with the mother, and as well as a haplomatch with the father. And amongst the siblings also, they are also haplomatches, all right? But of course, if you are parentless and you are childless, then there's no option for you. And this is very useful for especially countries like, say, China, whereby there is a one-child policy, you don't really have siblings to resort to. So if you have parents, your parents can still serve as donors. So nearly all patients then will have, if this is a successful transplant, mode of transplantation, nearly all patients will have a donor. It's immediately available because your parents are always around, and of course it saves you money from having to look for an unrelated donor or to procure an unrelated donor. So even in the early 2004, there are already investigators that are publishing on the advantage of using imatinib upfront and its safety as compared to all the other therapies that includes a stem cell transplantation. So if you look at the safety of imatinib, if you look at transplant, always there is an initial dip during the first 2 years because of the transplant-related mortality, and that is something that we just cannot overcome, all right? This is a study that I think you saw yesterday, which is a prospective study comparing drug treatment versus stem cell transplant as a first-line therapy. The problem with looking at registry studies is that there are always biases in registry. Obviously, younger patients, more fit patients are selected for transplant. Older patients are selected for drug therapy. They're never equal in terms of their population characteristics. These investigators from Swiss and the German CML group tried to do what we call a genetic randomization, whereby they have 354 patients and they just divided, if you have a matched sibling, you go for transplant. If you didn't have a matched sibling, you go for drug treatment, so that there is no biases regarding your characteristics, your fitness, the disease, and so forth. And actually, 91% of the patients who had a HLA match really did go for a transplant. And you can see, of course, the drug therapy does better than, at least during the first 8 years or so, all right? Although they match here at 8 to 9 years. And you can see transplant always has this dip, all right, during the first 2 to 3 years because of these transplant-related complications. But once you get through the 2 years or so, then generally your curve flattens out. And it is this dip that is always the problem, that we can't overcome in stem cell transplantation. So should every patient have a trial of TKI? I would say yes, depending on your country access. And I think generally most countries should have an access to which TKI to use as a first line, I think is still currently debatable, depending on your country access. What if they fail the first line according to the ELN criteria? Should they go to the second line or should they go to a stem cell transplantation? Again, it is very difficult because it depends on your country's access, whether you have an available second line. But I would say that it also depends on the loss of your response type. If your loss of response is that you are progressing, meaning that you are developing acceleration phase, generally we will say that, that your likelihood of having a good response to a second line is less. In which case, and definitely, of course, if you are transforming to a blast crisis. Mutation analysis, we talk about the T315I. So I think there is still a role of stem cell transplantation, for patients who fail the first-line therapy, depending on what are the failure criteria. This is a graph just to show you that having the TKI before the transplant really doesn't affect the outcome, of your transplantation. So it is all right to have a course of TKI, use that as a response, and then depending on that, make a second line. So how then do we decide who to transplant? We talked about that. So you really need to do your risk score for TKI, your response criteria, your SOCOL scoring. Unfortunately, as I mentioned, the SOCOL scoring tells you your probability, but really doesn't tell you what for you has an individual characteristic. So you really still need to go on the TKI first and look at your response criteria before you decide. Then, of course, there is a risk score for transplant as well. It depends on various factors, your age, less than 20, 20 to 40, more than 40, what is your disease phase, how long the delay before you went to transplant. And from that, you can also have a risk score and tells you what is your outcome. Your local factors is very important. What is your country drug access, If you have very limited access, you only have imatinib, then obviously if you fail imatinib, you have to go to a stem cell transplantation because you don't have much choice. What are the availability of transplant centers and experience? And we talked about that. Unfortunately, those who have access to TKIs also have access to transplant facilities, and therein lies the maldistribution of services. Are there any particular patient factors? I think adherence perhaps is something that's not really addressed these 2 days, but it's something that we should consider, patients, and there are enough data to say that those patients who are not adherent have poorer cytogenetic response, loss of cytogenetic response, and poorer event-free survival, So it is important. And whether there are any particular patient subsets that should go for a stem cell transplantation. And for us, our difficult subset are really the adolescents, because we treat patients above 12, So some centers treat patients above 20, and adolescents are really the most difficult group to treat. And not just in CML, it's also for ALL or anything that requires long-term therapy, because they don't listen to you. They are rebellious, they're not adherent to their treatments, and most of our adolescents, they lose response, So I think whether there's any specific subsets of patients, and we always fight amongst the hematologists to say, whether adolescents are better treated by the pediatricians than adult hematologists, because the adults tend to take adherence as granted. We tend to treat them like adults that they know what to do, whereas the pediatricians tend to treat them like children. So they're very instructive, They will monitor them, they will not believe them, so they will make sure that their parents, whereas the adults, we tend to treat them like adults. We say, you go take your medicine, and we assume that they have been taking their medicine, I think that is a very important, I won't go through this. So I'm just going to tell you about this publication that came out from Mexico, that looked at 72 patients whereby, they didn't have drug access in some institutions and they have drug access in another institution. So 22 of the patients who went to this hospital did not have access, 50 who have access, and they found that by doing a reduced intensity transplant for these patients, they have just as good outcome as TKI. So different countries may have to make their different difficult therapeutic choices for their patients, So what is the cost of imatinib in Malaysia? It roughly costs about 34,000 per year. What if we were to use nilotinib as first line? It actually increases it by at least 30%, per year. The Dasatinib is available at 47, so slightly cheaper than nilotinib. What is the cost of an allogeneic stem cell transplantation in Malaysia? It's a one-off thing, roughly if it's an uncomplicated stem cell transplantation, it's about 15,000, In the private, it will cost you about 46,000 US. In India, I think, and this is published by the Christian Medical College, it's about 15,000. And I reckon that it must not have increased a lot because India has a lot of generic medications, that includes transplant drugs. So roughly, I think it'll be about the same. In USA, in 2000, it cost you 100,000 to do a transplant. And, for every single complication, it adds on an additional 20,000 US to it. So it depends on, if you look at the cost, of maintaining this group of patients. And in Malaysia, you have this MyPad program whereby, all the patients that comes to the Ministry of Health, and I think it must be about 80% of the CML patients are treated on this MyPad program, where they get access to imatinib as first line and nilotinib as second line. Nilotinib has just been registered for first line following this year, so next year onwards, it will be available to them as first line as well. So these numbers are constantly increasing, all right? So we looked at the overall survival of the stem cell transplantations that we have done over the past 15 years. So we also get about 60% if you are in a chronic as well as blast crisis. So we compared those in acceleration, chronic who had an allogeneic transplant, and those who had TKI in chronic, which is the green line. So you can see that, always during the first 2 years, there's always this drop because of this transplant-related mortality. All right, and then subsequently they even out. We always lose this group of patients because of the transplantation. But if you were to take away those people who are not adherent, so from our registry and our case notes, anyone who has been reported to be non-adherent, and we just look at those patients who are adherent, you can see this is the curve of those who have TKI on chronic phase. All right? So they are better than those who receive a stem cell transplantation. Of course, for acceleration phase, those who went on TKI did worse than those who went on the transplantation. And this is from our registry data. So what are our options? We talked about that. The world is divided today into two, those the have-nots and the ones who have. And I think it is important that, for those who are have-nots, have to come up with some national guidelines. And the national guidelines should comprise of people from within your ministry, your physicians, as well as advocates like yourselves, to sort of decide then, what should be your first line, standard first line, what should be your monitoring, and what should be the second line, transplants and all that, such that I think every country must have a guidelines that is workable for them. We can adopt an ELN guidelines, but but there are many things that are not accessible to you. So, so that patients and doctors know where their stand is. So we don't have patients like yourself not being happy because you're not being monitored in a certain way that is recommended by an international consensus. And then there's the other end, there are physicians who are monitoring you in a certain way based on the limited resources that they have, not because they want to or not because, but they have to because this is as much as they can do. So perhaps that may be one option to go. Thank you very much.
My question is, after the transplantations, if unfortunately the CML come back again, can the patient just take the TKI, then it get control?
So in the past, when we didn't have a TKI, what we do is that we monitor even after a stem cell transplantation, and even after 3-4 years, we still continue to monitor you at least yearly by way of your PCR. And and what usually we do is that if we can detect any presence of the CML, that means you are relapsing molecularly or by cytogenetics, we will give you what we call donor lymphocytes. That means we will get the donor to come, harvest more lymphocytes, which are the immunoeffector cells, and that seems to work in a big proportion of people. That itself has its risk. But today, of course, again, because of the availability of TKI, is a much safer option. So many of us will monitor you, and if we show any relapse, we will use TKI, and some of us will also combine TKI with what we call DLI, the donor lymphocytes, and in many of these instances, it works, especially if it's early relapse.
Hello, doctor. I am a CML patient. I'm now on ponatinib and I have T315I, and my doctor in Singapore, he recommended me to go for a transplant. And because among my sibling, I have 5 siblings, but they are not much with me. I have only one brother who is 15 much with me. 15 much, yeah.
This is a haplo match. Haplo identity.
Yes.
Match, yes.
So, like, if I go for transplant, be it able like to do it with my brother or not?
I think this.
And
Yes. Sorry.
the other question, like you said earlier, that it's hard for the patient to find a donor, so they can do it with the cold blood transplant, right? So is it better than from the sibling or not? Yes.
Currently, as far as it depends because many depends on the transplant center experience. Some transplant centers have a lot of good experience with cord blood in adults. And, and based on those experience, they are very comfortable to use cord blood. We, as a center, we have done cord bloods as well. Our experience is not as favorable. So, but we also recognize that we are just starting to do haplo. Most of the centers have been doing this so-called 50% match or haplo match from their parents or from their siblings over the last 2 years or so. There are some very good data coming up from China, but the problem with transplants is that it's very center specific, meaning that, there are centers that are really having a lot of experience, centers who have less experience. So I reckon Singapore has very good experience. So, you should really sit down and talk to your doctor as to what is the outcome from their haplo or their cord, what is the risk, because most of us will have a registry. Then I think you are in a difficult decision, because if you are with a T315I and you are responding well with ponatinib, and do you now want to switch gears, and do a transplantation? This, to me, is a very personal decision, something that you really need to discuss with your physician, sit down and talk about the risks, all right? So one of the options could be, since you are still doing well, to monitor you very closely and see, but if you are starting to lose response, early, then that may be one time that you want to switch gear and move to a second alternative. That may be, I've had patients who are very well come to me, unfortunately the transplant outcome is poor. They get a mortality, then family gets very upset, I'm so well, I walk into a transplant center and then someone else goes out on a ventilator, for instance. Again, there is this scoring that, we cannot predict for an individual. You could sail through a transplant without a problem. You can get also very bad graft versus host disease or transplant. It has to be a very personal decision between you and your physician.
Nice to meet you. My name is Park from Korea. I had a transplant 2 years ago, and after that, relapse happened. And now I'm taking TKI again. When do you think is the correct point to start TKI? If my PCR level goes up, like 0.01 and 0.1, when is the correct point?
Again, it's a difficult answer to give you. Sometimes, depending on which phase of the CML that you are transplanted in, whether you were in accelerated blast phase and chronic phase, and usually during the first 6 months or so, your PCR will still remain positive. So sometimes we don't act unless it is quantitatively increasing in transcripts. But if you are still persistent, very low, most of us would probably wait for a while and see. And then, but usually beyond 6 months, and especially beyond 1 year, if you're still positive, then likely, you should go back on a TKI. Some of us are a little bit more proactive, because some of us, if we are transplanting you in blast phase or accelerated phase, we know that your chance of relapse is higher. We tend not to wait for the PCR, so we go on what we call a prophylactic approach. While you are still good, we put you prophylactic TKI. Duration, we don't know, maybe 1 year, maybe 2 years. Most of us would just logically, reasonably just say, put you on 2 years, and then subsequently, if you are PCR negative, consider taking off the TKI. So practices varies, in a transplant community.